Good evening, everyone. Yashoda Group of Hospitals welcomes you all for the academic activity of this week. And this week, we have an interesting, rather a new topic regarding the trauma in the geriatric age group. The management of trauma in elderly is indeed a challenge for the emergency room physician with various factors, confounding factors, and other factors like the comorbidities, the medications the elderly age group use. And this always is always a challenge for the emergency room physician. The physiological changes that happen with aging, these factors, they further add burden in diagnosis of these patients and management of them. So it's prudent to see how the management of this age group varies compared to the other age group patients. And all of us would have heard the famous saying about the pediatric age group, that children are not miniature adults and they have their own physiology and need different kind of management. Similarly, the elderly age group who are at the other extreme of age, they also need special attention. They have their own kind of physiology and they need a different kind of care. And let us see what are the factors that make the management of this age group different. So in this first, let us see a case presentation by Dr. Bhavana, our emergency room resident, and followed by a presentation about the basis of this varied presentation. Okay, so with this, I give over to Dr. Bhavana.
Good evening. I'm Dr. Bhavna, ER resident. Today, my case presentation is about a 71-year-old male who presented to ER with allegedly being found beside a staircase by his wife. Attender gives a history of 2 episodes of vomitings since the morning. History of difficulty in walking and pain in the right side of hip is present. There is no history of loss of consciousness, seizure activity, bowel and bladder incontinence, fever or cough, no history of recent LRTI, and no similar complaints in the past. On primary survey, airway is patent, no C-spine tenderness is seen, and breathing is regular with the respiratory rate of 26 breaths per minute, and saturations were 91% on room air, with a decreased air entry in the right lower lobe. Circulation, BP is 110 by 80 millimeter of mercury with warm peripheries, with GCS being E3, V3, M5. Patient is drowsy and pupils were bilateral 2 millimeters reacting to the light. GRPS is 47 milligram per deciliter and temperature is 99 degrees Fahrenheit. Primary adjuncts, ECG is showing AF with controlled ventricular rate with a heart rate of 86 per minute. EFAST is negative and 2-day echo screening is suggestive of fair LV function with no regional wall motion abnormality, and IVC is collapsing with 1.1 centimeters. ABG POCT is taken on room air showing decreased electrolytes with sodium being 119, potassium 3.4 and chlorine 90. Glucose is 52 milligram per deciliter. On ample history, no known past allergic history, and patient is on regular medication for hypertension, type 2 diabetes, dementia, coronary artery disease, and AF with controlled ventricular rate. Patient had a past history of right TKR 15 years ago and is status post 2 doses of COVID-19 vaccination. Last meal is 14 hours ago, and events leading to the current illness were that patient was found on the floor beside the staircase with an unknown mechanism followed by 2 episodes of vomiting. On secondary survey, patient is a lean male with a 4 into 5 centimeter abrasion over left frontal region, 2 into 3 centimeter abrasion over right side of the thorax, just below the nipple. Pain, tenderness, and restriction of movements in the right side of hip. Chest compression test is positive on the right side. On systemic examination, patient is having abrasion over right frontal region with no other external injuries or deformities. GCS is E3, V3, M5 with pupils bilateral equal reacting to light. Patient is drowsy but localizing to the pain. Respiratory system, on inspection, trachea is in center and an abrasion over right side of the chest, right below the nipple, is seen with bilateral equal chest rise, and respiratory rate is 26 breaths per minute. On palpation, patient is having tenderness at the level of 4th and 5th ribs at mid-axillary line. And on auscultation, there is a decreased air entry in the right lower lobe and dullness in the right lower lobe on percussion. Cardiovascular system and GIT have no significant changes. Provisional diagnosis is traumatic brain injury, blunt trauma to the chest, right hip joint or femur fracture. ED stabilization, 2 large bore IV cannulas were secured, followed by injection 25% dextrose 100 ml IV and O2 support of 3 liters per minute initiated via nasal pumps. IV fluid 0.9% normal saline is initiated at 80 ml per hour. Secondary adjuncts. Patient was sent to CT polytrauma. The CT polytrauma positive signs being left frontotemporoparietal SDH with mass effect and 11 mm midline shift towards the right with mild perilesional edema. And CT chest is suggestive of minimal hemothorax on the right side with 5th to 7th rib fractures. CT pelvis is suggestive of right femur IT fracture. This is left frontotemporal SDH with mass effect and perilesional edema with midline shift towards right. The CT chest is showing pneumothorax with rib fractures. And this is right IT fracture. Force in the ED. When patient was brought back to ER from imaging, the GRBS is 116 milligram per deciliter. GCS deteriorated to E2, V2, M4, and BP is 140 by 80 millimeter of mercury. And respiratory rate is 32 breaths per minute, and pulse rate is 98 per minute. Endotracheal intubation was done in view of drop in GCS to secure the airway. All the appropriate specialties were notified, and IV mannitol or 100 ml administered, followed by injection Levipil 1 gram IV. Infusion of 3% NaCl at 10 ml per hour IV is initiated along with pain management. Right ICD is placed in view of hemothorax. Patient was shifted to OT for decompression and is later planned for ORIF of right femur. Thank you.
So that was a case presentation which showed that the management of trauma in the geriatric age group is not only confined solely to trauma. Even the medical issues have to be addressed simultaneously with the management of trauma. Not only the medical management, we need to think about the associated injuries as well. Even with a trivial trauma, there is a chance for serious injuries in the elderly age group, which may be because of the various physiological reasons, the underlying comorbidities, and various other factors. So let us see what is the basis of the various injuries seen in this age group, even with a trivial trauma or serious trauma. So I give it over to Dr. Shravani, our emergency room physician, who will further throw light on these aspects of geriatric trauma and its management.
Yes, sir. I'm not able to get the full screen, sir. Yeah. Yeah. So am I audible?
Yes, ma'am.
Yes, you're audible, Dr. Shravani.
A warm good evening, everyone. Myself, Dr. Shravani, emergency physician working at Yashoda Hospital, Secunderabad. There's a problem again. So is my screen visible?
Yes.
Yeah, now we are able to see it.
Can you please close the complete PPT and open it again?
Okay.
It's not clear. Make it from current side on the top.
Mm. Okay.
Yes, now it's visible. Continue.
Yeah. Today we are going to discuss regarding the geriatric trauma. We have just completed a geriatric case presentation. Let's now discuss the salient points in the geriatric trauma and check how it differs in the management from other age group. I know it doesn't sound interesting when we look at the topic, but this topic is really very important as we are seeing a rise in trauma in the elderly and it's expected to increase in the near future. So what exactly is geriatric? Dictionaries define geriatric as pertaining to the older people. But as per the WHO, it states middle age as the age group between 45 to 79 years, group between 60 to 75 years as elderly, and age more than 75 years as old. And most of the developing countries have accepted the chronological age of 65 years as defined as elderly or older population. Coming to the demographics of geriatric age group, studies by the United Nations propose that India's older population will increase drastically over the next 4 decades. That is around 34% by 2050. And aging is expected to be one of the most significant transformations of 21st century. And the reasons for these are increase in the life expectancy. This generation lives longer and will have access to the high quality healthcare system for a better social support and a better nutrition. There are many pre-existing conditions which affect on aging. Among them, these 5 pre-existing conditions like diabetes, hypertension, CAD, COPD, CLD, coagulopathy are more vulnerable in causing aging, leading to high morbidity and mortality. When you look at the mechanism in the geriatric trauma, it is similar to that of a younger trauma, but only difference is the elderly population have a significant higher mortality rate even with a small impact. These are 5 most common mechanisms in geriatric trauma, the most common being fall, followed by motor vehicle collision. Then comes the pedestrian trauma, burns and assault. Younger patients, they usually fall. When they fall, they get up, dust themselves and go back to play. But for elderly, it is different. Trivial falls may lead to life-threatening injuries. And it's expected that fall is #1 cause in elderly, involving most trauma to the head, pelvis, and lower extremity. It accounts for 40% of death. There are many factors affecting the fall, like poor vision, impaired balance, decreased reflexes, and impaired hearing. And the second most common cause of trauma in the developing countries is motor vehicle collision, usually occur during the day within their neighborhood. Accidents may happen cause of several reasons such as impaired vision, impaired hearing, poor reflexes. Older population usually have a cervical arthritis, cervical spondylosis. They may lead to impaired peripheral visibility, leading to accidents. The third most common cause in trauma is burns. Simple burns, even as low as 5%, have a high morbidity and mortality due to physiological changes. A few being skin changes, there's altered nutrition, this lead to increased risk of infection. They lead to delay healing due to decreased collagen content in the tissues. So most elderly patients with burns are devastating. They usually have really very poor outcome. When you look at the trauma in the elderly pedestrians, it is noticed that 1 in 5 are killed and 1 in 10 are injured. The main causes noticed are elderly patients are often confused. They have a gait imbalance with decreased auditory and visual sensations. So now we'll discuss some important system and see the changes with aging. 50% of people with age, when you look at the cardiovascular changes, 50% of people with the age more than 65 years have CAD. Age increases the myocardial stiffness with slower electrophysiological conduction due to increase in the arrhythmias. So decreased sensitivity to catecholamines occurs usually during accident. The flight or fight response occurs leading to catecholamine surge. In normal person, they respond with increase in the heart rate and increase in cardiac output. But in the older people, they respond with increase in the blood pressure. As they already have increase in the baseline high BP, it is difficult to assess if the patient is really in shock and is responding to hypovolemia or not. Respiratory system changes. The chest wall is fixed and rigid in the elderly. There is a decreased strength due to decreased chest wall compliance, loss of strength in the muscle, decreased cough reflex, all these leading to high risk of respiratory failure, risk of aspiration occurs, and pneumonia. Hence, an elderly patient with even a simple rib fracture may have a high risk of respiratory failure and pneumonia, and mostly be ventilator dependent. Don't underestimate a rib fracture. Somebody comes with a rib fracture, we give adequate analgesia, if requires oxygen, do observation and discharge. This is okay for the elderly age group, but for the older people, it's different. There was a study conducted showing that age group more than 65 years old has 90% increase in mortality for every rib fracture. So every elderly patient suspecting rib fracture with even a simple rib fracture, they need to be admitted in an intensive care unit for the observation to look for any deterioration. Central nervous system, usually brain atrophies with age. By 70s, the brain decreases in size by 10%. So here you can see two CT images. One is a normal healthy brain, the other comes the cerebral atrophy. You can see there's a decrease in the gray and white matter. Ventricles are large and the brain shrinks and pulls away from the skull. This put the tensions on subdural vein. So even with a simple blunt injury, as there is a gap between the skull and the brain, it increases the tension on subdural veins leading to subdural hematoma, even with a minor impact. Also, these patients have osteoarthritis of the spine. So many elderly patients have cervical spondylosis. So even with a simple fall, they may have severe spinal cord injury due to the cervical stenosis. So it's very important to maintain the cervical spine in neutral position, that is application of cervical collar. And when you intubate a patient, you have to maintain the C-spine stabilization. We do normally for every suspected cervical trauma patient, but in elderly, even a minimal manipulation can cause minor spinal cord injury to the severe spinal cord injury. So C-collar application need to be applied for any trauma patient until the spinal cord injury is clear. So these are few underlying disorders or diseases that come in with which make a clinical assessment difficult. Like if you want to access a patient with underlying subdural hematoma, and if patient has a dementia with underlying CVA, it will make an assessment very difficult. So always take a proper history even from a family. Dementia, CVA, decreased reflexes, peripheral neuropathy, impaired balance, decreased visual and auditory activity, decreased peripheral vision, memory impairment, Alzheimer's disease, all these factors interferes with the recovery too. And when you look at the renal changes with aging, there is a decrease in glomerular filtration rate. So many patients have a renal artery stenosis. So lead to increased risk of electrolyte imbalance, volume overload, impaired clearance of prescribed drug. Due to renal impairment, urine output, which we think as an end point of resuscitation, is not so reliable indicators in elderly people. So we usually think if our creatinine is normal, we have a very good renal function. But for elderly, it's not. So always look for a creatinine clearance and GFR. And as aging happens, skin atrophy occurs. There is a decrease in water content in the cell, decrease in the subcutaneous fat, leading to increased risk of hypothermia and predispose them to decubitus ulcers. When you look at the musculoskeletal changes, as aging occurs, osteoporosis occurs, leading to decrease in the muscle mass, increased risk of fractures. There are five most common areas of fractures which are noticed, like ribs, proximal femur, hip, humerus, and wrist are most common areas of fracture. And the fracture is our number one cause of morbidity. The patients will be admitted for a longer time in the hospital. When you look at the metabolism of elderly patient is also impaired in elderly patients. Thyroid and thymus gland fibrosis occurs, so they don't function well. There is a decrease in the T cell immunity leading to glucose tolerance and malnutrition. Dyselectrolytemia can occur. All these factors lead to increased risk of infection. So if they have traumatic wounds, any perforation, all these are predisposed to severe infections, pneumonia. So we need to address this thing and start on appropriate antibiotics early. So most of the elderly patients have underlying 2 to 3 pre-existing comorbidities and may be on multiple medication. This medication can interfere with the clinical presentation, with trauma, and even with treatment. The most common medications they use are cardiovascular medications like beta blocker, calcium channel blocker, anticoagulants like warfarin, antiplatelets like aspirin, clopidogrel, oral hypoglycemic agents, steroids, diuretics, and psychiatric medication like benzodiazepines and antidepressants. When the patient is on beta blocker, usually the beta blocker prevents tachycardia. Any trauma patient presenting to ER in shock has tachycardia, but due to underlying medication, use of medication, an elderly individual in shock may not present with tachycardia as they have a subnormal response to catecholamines. So don't be carried away with a normal rate of 70 as a normal. Anticoagulants most commonly are warfarin is used. Any patient's use of warfarin with underlying, if patient is having trauma, there might be increase in the INR. So you can reverse the effect of it with either by vitamin K or FFPs. Use of steroid decreases the immune response, making them prone for the infections. And the psychiatric medications like benzodiazepine and antidepressants, they lead to drowsiness and altered mental status. This sometimes contribute to the fall and recovery too. Some elderly patients come to the ED. When they come with trauma to the ED, they come in with some accessories like pacemaker, hearing aids, glasses, dentures. Pacemaker, you could see the pacemaker, if they come with pacemaker, you could see the pacemaker indented or during an examination or in a chest x-ray, you can see it. This can prevent tachycardia. So if the patient is in shock, it is difficult to assess. Hearing aids, like if you're talking to a patient, if the patient is having a hearing aid, it might have fallen at the car accident. When you talk to them and if they have staring looks, not responding, we should know is it because of a hearing impairment or due to low GCS. And they may or may not have glasses. So if you do vision tests, you should be able to figure it out if they can really see or lost glasses at the trauma site. Elderly population are mostly in suboptimal nourished state due to inaccessibility or due to unavailability of nutrients, decreased glucose tolerance, decreased renal clearance. All this affects the morbidity. Elderly maltreatment or abuse is something which is important. Non-accidental injuries like elderly abuse is an frequently overlooked aspect in the geriatric trauma. A patient coming from the nursing home and history is they fell and nobody witnessed it. There could be a possibility of abuse. So there are 2 million abuses per year. Among this, 5 out of 6 get unreported. And it can be, there could be many kinds of abuse, could be a physical abuse, sexual abuse, financial abuse, emotional abuse, and neglect. So how can we improve the trauma care in the elderly patient? We divide it into a pre-hospital management and the ER care. Pre-hospital management. EMS providers should be aware that even a minor injury in the elderly should be transported to a nearest trauma center. Simple can often be a life-threatening. So how to determine the injury severity in the field? There were many scores like Apache, injury severity score, but the basic simple score used is trauma score, which includes respiratory rate, systolic blood pressure, GCS, and capillary leakage. In 2016, American College of Surgeons recommend all patients more than 55 years age to be transported to the trauma center regardless of injury severity. When an elderly trauma patient enters the emergency room, vital signs may often be misleading. They may not be hypotensive or tachycardia. A thorough initial assessment is necessary to avoid mistriaging. Always take a good history. Sometimes in a patient with dementia, history taking may be challenging. So you have to slow down yourself and ask questions repeatedly. There was one large retrospective study shows that 49% of elderly patients who present to emergency department are mistriaged. And the principles of ABC are same as with of younger patients, except for a few physiological changes which need to be paid attention to. So I'm not going to discuss much in detail regarding this ABCs. So A for airway, like in elderly patients with airway, there will be a cervical spondylosis most common in elderly population. You should be more careful during intubation. So because of cervical spondylosis, they usually make it difficult during intubation. Usually they have a Mallampati of 3 or 4 scole, decrease in the neck rigidity occurs. So it makes that intubation very difficult. So there is even a reduced respiratory reserve, which need to be kept in mind. Think of early or elective intubation, anticipate a difficult airway. Always keep help at hand. And the tissues on the inside of the nose are thinner in an elderly patient and they may bleed faster. So you should be very careful during an intubation and or during even a rise tube insertion also. Breathing or ventilation. You should be aware that chest is fixed, rigid structure and has decreased functional residual capacity. So has high risk of respiratory failure. They have a decreased cough reflex, decreased mucociliary clearance. This all leads to increased risk of aspiration. C, circulation. You have to realize that they may not have a good peripheral pulses because they might got peripheral vascular disease. Not because they are in shock, they may have calcified arteries. So you should always remember that adult physiology. Always remember the adult physiology and correlate that with the examination. Always watch for the signs of occult shock and ensure adequate crystalloid resuscitation, assess the cardiac status and volume responsiveness. Always pay attention to the comorbidities and medications. Constant reassessment is a key in the elderly patients. Coming to the disability, as we have seen in a previous slide, cerebral atrophy occurs with age. Even with a mild impact, it could be a life-threatening. On top of it, the pre-existing conditions like dementia, delirium, and use of antipsychotics make the assessment very difficult. So always liberally use CT imaging to identify brain and spinal cord injuries and ensure reversal of anticoagulants like warfarin by giving vitamin K or FFPs. Elderly patients have a loss of subcutaneous fat and loss of skin elasticity. All this increased risk of hypothermia. So always risk of hypothermia need to be kept in mind. Once the patient is under our care, we need to protect the patient. The patient had a fall at home, we need to prevent further fall in the hospital. So you have to prevent further fall, avoid over sedation. Sometimes if the patients are very agitated and confused, we tend to give more sedation. So avoid it and first assess the patient and avoid over or under hydration, look for the electrolyte imbalance. Inquire about the living will early on admission because when the patient is kept on ventilator and no family is around, no documentation, decision making might be much more difficult. And address the comorbid conditions and don't assume confusion is just an ICU psychosis. The trauma patient has change in the mental status. First thing which we need to rule out is an expanding hematoma, cerebral edema or worsening of any secondary brain injury. So get an immediate CT scan. Next is hypoxia. This can cause change in mental status and make sure patient get appropriate oxygenation. Sometimes change in mental status may be due to some change in medications also, or hypotension can even cause altered mental status. If all these causes of change in mental status is ruled out, then think of the ICU psychosis. Trauma may not be a triggering event in a large number of geriatric patients. As we saw here in our case study, hypoglycemia is the cause of fall. So a medical event may have caused it. So like MI, myocardial infarction, arrhythmias, stroke, transient ischemic attack, hypotension, and hypoglycemia. So ensure proper history taking and a thorough assessment in all the elderly trauma patients. So we have taken care of a patient. Now, proper disposition of patient is of our utmost importance. So always involve the social services, address home living condition leading to the trauma, treat the osteoporosis and other medical conditions with a regular follow-up visits. We should make sure they have appropriate hearing aid, glasses, and a walker. Always consider assisting living like nursing home. So coming to the summary, anatomy and physiological changes in the elderly are associated with increased morbidity and mortality. The vital signs may be normal when the patient is actually in the shock. So a seemingly minor trauma can cause a severe life-threatening injuries in the elderly. So aggressive care is generally warned. Always consider pre-existing conditions. Anticipate complications. Don't minimize discharge planning. So always pre-morbid status has to be considered more than a chronological age. Consider early transport to trauma center. And the vitals and the urine output are not absolute values to consider. Physiological examination may underestimate the injury. Use of radiological studies are indicated. Thank you.
So that's a very extensive and in-depth analysis of all the factors that are involved in the management of geriatric trauma. So now let us proceed to the questions in the chat box. Can blood pressure be considered as a marker of instability in elderly patients with trauma? Okay, this is a very good question. I'll take this question. Yes, the blood pressure measurement is a very important thing that we rely on while treating patients of trauma. This is a very important thing in all the age groups except the elderly. The blood pressure is always misleading in case of elderly patients. This is because the incidence of hypertension, it approaches 90% and above in the geriatric age group. So it's always prudent to have a higher cutoff value for hypertension in the elderly age group. A recent study has shown that in blunt trauma patients who are more than 65 years of age, there was an association between hypotension and mortality, starting with a systolic blood pressure of less than 110 millimeter mercury. 110 millimeter mercury, we consider it as normal blood pressure in younger age groups. But here it was associated with mortality. So it is reasonable to have more conservative cutoffs as markers of abnormal vital signs in the geriatric age group. And also there's a guideline which says that a decrease in blood pressure of 30 millimeters mercury below a known baseline for this patient, or a falling trend. These can be considered as markers of instability in these geriatric age group patients. I think I have answered this question well. So the next question is transportation risk high for the elderly patients? I think Dr. Shravani, can you answer this question?
Yes, sir. Yes, the rate of pre-hospital under triage are higher in the older older than the younger patients, with significant increase in the mortality. So as we have already discussed, the triaging with heart rate and blood pressure are not reliable indicators in the elderly population. So most of the EMS providers should triage with a simple trauma scale like respiratory rate, GCS, capillary withdrawal. And as per the ATLS, it states that the patient who are more than 55 years age group is transported to the trauma center regardless of injury severity. And the elderly can rapidly develop tissue damage leading to decubitus ulcers. So always consider padded backboards or vacuum splint for prolonged transport. And patient with cervical kyphosis may need firm padding behind the head with a spine immobilization in order to prevent forcing the spine in the abnormal positions.
Yeah, adequate measures have to be taken in case of transportation, especially the pre-hospital management of the geriatric age group. So next question is, how is shock treated in these patients? Dr. Bhavna, can you tell us about the shock management in geriatric age group?
Yes, sir. We initiate with small volumes of crystalloid solutions, isotonic crystalloids, be it normal saline or ringolactate, assessing for the patient's response to avoid under resuscitation or fluid overload. We consider blood transfusion depending on the injury of the patient and severity of the blood loss after 1 to 2 liters of crystalloid resuscitation.
Yeah, fluid resuscitation is a very important thing. Here we need to keep in mind and see that the patient is neither undertreated nor overtreated. That is, we have to avoid the overload of fluids in these patients because of underlying comorbidities, the cardiac status, and other factors. Okay. The next question is, does traumatic brain injury in elderly differ from that in the general population? Yes, I'll answer this. Yes, the traumatic brain injury in elderly is very much different from the general population. For example, in the elderly age group, there is a very less incidence of epidural hematomas when compared to the general population. Whereas the incidence of subdural hematomas and intraparenchymal bleeds or hematomas is more in the elderly age group. This is because with aging, there is a shrinkage of the brain tissue that gives more space within the skull, and once the brain parenchyma shrinks, there is a pressure on the bridging veins, and stretching and tension of these bridging veins causes bleeds even with trivial trauma, and this results in subdural hematomas. Whereas in case of whereas between the dura mater and the inner table of skull, there is a dense fibrous tissue that prevents the formation of epidural hematomas. In this way, the traumatic brain injury presentation varies in the geriatric age group. So coming to the next question, how are the what are the precautions for blunt trauma chest management in these patients? I think Dr. Shravani, you can tell about this.
Yes, sir. So most of the blunt trauma to the chest, they usually present with rib fracture, pneumohemothorax, flail chest, pulmonary contusion, cardiac contusion. They usually quickly lead to decompensation because of underlying baseline respiratory insufficiency. So in such kind of patients, pain control after chest wall trauma becomes vital. And early intubation and ventilatory support is really required to reduce atelectasis and risk of further infection. In such kind of patients, pain control is really challenging because the elderly may have decreased tolerance to the opioid analgesics, which can have effect on respiratory, leading to hypoventilation. They may have an imbalance in the hemodynamics, lead to hypotension, and CNS effects like imbalance and delirium. So we should be cautious even while giving opioid analgesics because they may also cause delirium, decrease balance, and impaired ambulation.
Okay.
Okay, sir.
Yeah. The next question, how are the cervical spine injuries dealt in elderly? I'll answer this question. The incidence of a cervical spine injury is double or twice in case of elders when compared to the younger cohorts, especially the odontoid fractures. They're particularly common in the geriatric age group. And why are these people prone to these kind of injuries more than the other age groups is because of pre-existing cervical spine pathologies such as osteoarthritis, the bulging discs with aging, and osteoporosis. All these predispose these patients to the spinal cord injuries. Not only this, while the diagnostic imaging is also a challenge, reading these CT scans, the plain radiographs, that is also a challenge. And most of the fractures are missed on plain radiographs in case of geriatric age group. That's why CT scan is preferred initial modality itself. Directly go for a CT scan of the cervical spine rather than a radiograph in case of elderly age group. And another thing is that many fractures in one section of spine are accompanied by fractures in another section. So identification of one fracture should prompt imaging of the entire spinal column and not the local area. That is the one important thing we have to keep in mind. And so going ahead with the questions, how is shock identified in elderly if the vitals are unreliable? Okay, Dr. Bhavna, can you tell us about this?
Yes, sir. As the vitals are unreliable in the geriatric patients, the initial indicators would be base deficit and lactate levels, whose serial evaluation and measurements which help in our further resuscitation of the patient. As increased lactate levels indicate the systemic hypoperfusion and correlates with the patient's length of stay and his mortality.
Yeah, base deficit and lactate levels are very important in management or assessment of trauma. And moreover, the serial lactate levels are very important in guiding us the treatment regarding the treatment of these patients. Okay, so we're done with the questions also. I thank both of you, Dr. Bhavna and Dr. Shravani, for your extensive preparation and giving us knowledge about the geriatric trauma management. Thank you, one and all.
Thank you, sir.